pathway for fine touch, vibration, and conscious proprioception. This is the discriminative side of sensation, the channel that lets you feel texture, know where your limbs are, and tell 2 points apart. As we go, keep our organizing question in mind. Where does it cross? For this system, the answer is high, up in the medulla. Let's build it from the receptor up. Here's what I want you to be able to do by the end of this chapter. First, trace the 3-neuron chain from a mechanoreceptor in the skin through the dorsal root ganglion, up the dorsal columns and the medial lemniscus to the thalamus and the cortex. Second, localize the decussation. Pinpoint where this pathway crosses as the internal arcuate fibers in the caudal medulla. Third, apply the T6 rule. Separate fasciculus gracilis, the lower body, medial, from fasciculus cuneatus, the upper body, lateral, along with their nuclei. And fourth, the payoff. Predict the deficit. Reason from a dorsal column lesion straight to loss of vibration and proprioception, sensory ataxia, and a positive Romberg. Notice that every objective moves in the same direction, from anatomy to the bedside. That's how we'll work the whole chapter. Before we walk the pathway slide by slide, here's the whole system on one screen. On the left, what it carries: discriminative, fine touch, texture, form, precise localization, vibration, the thing you test with a tuning fork, conscious proprioception, joint position and movement, and 2-point discrimination. All of it rides on large, fast, myelinated A-beta afferents. Big fibers for high-fidelity information. On the right, the 3-neuron chain, and I want you to learn it as a rhythm you can recite. First-order neuron, cell body in the dorsal root ganglion, enters through the medial division of the dorsal root, ascends the ipsilateral dorsal column. Second-order neuron, synapses in nucleus gracilis or cuneatus in the caudal medulla. Then its axons become the internal arcuate fibers that decussate and form the medial lemniscus. Third-order neuron sits in the VPL nucleus of the thalamus and projects to S1, the postcentral gyrus. Now the board anchor at the bottom because it's the single most useful sentence in this chapter. This pathway stays ipsilateral until the caudal medulla. So a lesion in the cord gives you ipsilateral loss below it. A lesion above the medulla gives you contralateral loss. Fix the crossing point, and the side of the deficit falls out automatically. Everything we do next just fills in this skeleton. This is where the dorsal column pathway begins, and its job is to teach the first-order neuron from skin to brainstem. Everything on it serves the 3 modalities in the subtitle: fine touch, vibration, and conscious proprioception. Look at the neuron, upper left. It's pseudo-unipolar, and notice its cell body sits out in the dorsal root ganglion, not inside the cord, which is exactly why a disease like tabes dorsalis strikes here. Now follow its central axon into the cord and up the center of the slide in 3 steps. It enters through the dorsal root, ascends ipsilaterally without synapsing, and makes its first synapse only up in the medulla, in the gracile and cuneate nuclei. Ipsilateral, no synapse until the medulla. That single fact is why dorsal column signs stay on the same side as the lesion. And watch the color as you climb. Green gracilis, medial for the legs, blue cuneatus, lateral for the arms, appearing around T6. Legs medial, arms lateral. The details panel and the 6-step table on the right are your roadmap. Steps 4 through 6, the crossing and the thalamus, are the next 2 slides. Pause here and read those boxes in full. That's what they're for. The one clinical point to carry: wreck this pathway and you lose vibration and position sense with a positive Romberg. The patient sways with eyes closed because they'd been using vision to replace the proprioception they've lost. Pain and temperature are untouched. Those ride a different tract. Next slide, we read all of this on a single cross-section. Frame 1 followed the neuron as a moving journey. Now we stop at one level because on a real MRI, you're handed a single cross-section and asked to read it. This slide teaches that skill. Orient first, every time. Top is posterior, bottom is anterior. Find our target in the posterior fasciculus, green Gracilis medial, blue Cuneatus lateral. Learn the neighbors now too, because we return to this exact section for every tract. The dorsal root and its ganglion, the dorsal and ventral horns, and the small lateral horn, the intermediolateral column, T1 to L2, which becomes the star when we reach the autonomic and anterolateral systems. Now the point of the slide, the red dashed T6 line and the two insets. Below T6, only Gracilis is present. The upper body fibers haven't joined yet. Above T6, both Gracilis and Cuneatus. So the mere presence of a cuneate fasciculus tells you you're at or above T6. Reason it, don't memorize it. Clinically, this lets you go from picture to deficit. Strike the dorsal columns and you predict ipsilateral loss of vibration and position sense below the level, with sensory ataxia and a positive Romberg. Medial Gracilis for the legs, lateral Cuneatus for the arms. Next, the neuron reaches the medulla, hands off to the second-order neuron, and we watch it cross. This is the crossing, and it is the hinge of the entire pathway, so slow down here with me. On the last two slides, the first-order neuron climbed the dorsal column ipsilaterally and reached the medulla. Now it finally synapses, and the second-order neuron takes over. Follow the numbered path across the center. Step 1. The first-order fiber ascends ipsilaterally. Step 2. It synapses in the dorsal column nuclei of the medulla. Nucleus gracilis medially for the lower body, nucleus cuneatus laterally for the upper body. Step 3, and this is the moment. The second-order axons sweep across the midline as the internal arcuate fibers and gather on the other side to form the medial lemniscus. Look at the decussation panel in the middle. Those fibers curving across. That single sweep is what makes everything above it contralateral. Let me make the consequence explicit, because this is where students lose points. Below the medulla, the pathway is ipsilateral. Above the decussation, it is contralateral. So a dorsal column lesion in the cord causes ipsilateral loss of fine touch, vibration, and proprioception. Read the clinical note at the bottom. It says exactly that. But those same modalities, lost from a lesion in the medial lemniscus higher up, show up on the opposite side of the body. Same pathway, opposite side, depending only on whether you're below or above this crossing. Drill that until it's automatic, because the next slide follows the medial lemniscus up through the brainstem to the thalamus. We've crossed, now let's ride the medial lemniscus up to the cortex. And pay attention to how it moves through the brainstem, because its position changes, and that change is testable. On the left, the course. In the medulla, the medial lemniscus sits near the midline, oriented dorso-ventrally, with the legs ventral. In the pons, it rotates to a more lateral, transverse orientation, and in the midbrain, it lies dorsolaterally, and here's the key relationship, right next to the spinothalamic tract. It then reaches its target, the VPL nucleus of the thalamus. On the right, the last leg. From VPL, the third-order neuron passes through the posterior limb of the internal capsule, fans out in the corona radiata, and lands on primary somatosensory cortex, S1, the postcentral gyrus. Remember the homunculus, the leg draped over the medial surface, the face down laterally. Now the high yield point at the bottom, and it comes straight from that midbrain relationship. By the upper pons and midbrain, the medial lemniscus and the spinothalamic tract are lying side by side. So a single lesion up there can knock out contralateral fine touch, vibration, and proprioception, and pain and temperature all together. Every sensory modality from the opposite side of the body. Down in the cord, those two systems are far apart. Up in the rostral brainstem, they've converged. That convergence is the whole reason a small brainstem stroke can produce such a dense, complete sensory loss. Now we cache the anatomy in at the bedside. This is the slide that turns the pathway into a patient. Start on the left, the deficits, and notice they're all predictable from what the dorsal columns carry. Lost, vibration, conscious proprioception, fine touch, and two-point discrimination, ipsilateral and below the lesion, because in the cord we haven't crossed yet. From that proprioceptive loss come the signs. Sensory ataxia, a clumsy, high-stepping gait, because the patient can't feel where their feet are. The Romberg sign, steady with the eyes open, but they sway or fall when the eyes close. And pseudoathetosis, slow, writhing movements of the outstretched fingers when the eyes are shut, because without position sense, the hand drifts and can't correct itself. On the right, where these pathways fail, the classic causes. B12 deficiency, subacute combined degeneration, which hits the dorsal columns and the lateral corticospinal tracts together. Tabes dorsalis, the neurosyphilis that attacks the dorsal columns and roots. Friedreich ataxia, which takes the dorsal columns, spinocerebellar, and corticospinal tracts. And rarely, a posterior spinal artery infarct. Now the exam trap at the bottom, and this is the one I most want you to carry out of this chapter. The Romberg sign tests proprioception, not cerebellar function. Reason it this way. A patient stays upright using three inputs: vision, the vestibular system, and proprioception. Take away proprioception, as in a dorsal column lesion, and they can still stand with the eyes open because vision compensates. Close the eyes, remove vision, and they fall. That's a positive Romberg. A cerebellar patient, by contrast, is unsteady with the eyes open or closed. Closing the eyes changes little. So Romberg positive means dorsal column or vestibular, not cerebellum. That one distinction separates two whole families of unsteady patients, and it is tested constantly. Here's the entire dorsal column story on one grid. This is your screenshot slide. I won't read every cell. Pause and let it consolidate. But look down the two columns and hold the contrast. Fasciculus gracilis, lower limb and lower trunk, present at every level of the cord, sitting medial, relaying in nucleus gracilis, graceful legs, medial. Fasciculus cuneatus, upper limb and upper trunk, present only at T6 and above, sitting lateral, relaying in nucleus cuneatus. The high yield line at the bottom is the T6 rule one more time. Below T6, gracilis only. At T6 and above, cuneatus joins it laterally. If you can rebuild this table from memory, you can read the dorsal columns on any cross-section. Next, we leave the discriminative system and cross to the other great pathway, pain and temperature. Chapter 2, the anterolateral or spinothalamic system,